Welcome to Didn't Get Frazzled presents Constipation for Patients. We will discuss the definition, alarm symptoms, underlying causes, and, of course, treatment of constipation. We're all familiar with constipation, but not everyone is familiar with the medical definition of constipation. For this, you'll need one of three problems: difficulty passing stool or straining, incomplete passage of stool, and reduced frequency. Normal bowel movement frequency varies from person to person and can be anywhere between 3 bowel movements per week to 3 bowel movements per day. If you have only 1 or 2 bowel movements per week, then you're constipated. A bowel movement every other day is completely normal. Alarm symptoms can be a sign of colon cancer and are listed on the slide. If you're under 50 and have no alarm symptoms, it's okay just to treat the constipation. If you're 50 or older, then you should be getting regular colonoscopies anyway. Be sure to see your doctor. Treating constipation is fine, and we'll get to that shortly, but it's always a good idea to assess for underlying causes. The first thing you want to ask is, are any of my medications causing constipation? Major offenders are listed on the slide. As you can see, many of these medications are over-the-counter, including antacids, iron, calcium, allergy medication, and pain medication. Talk to your doctor before stopping any prescribed medication. Your doctor may switch the medication to something less likely to cause constipation, reduce the dose, or try a drug holiday, where you stop the medication for 2 weeks, then restart to see if the constipation resolves and then returns. Drug holidays are especially useful for patients on many medications because it helps identify which of these many medications is the cause of your symptom. There are several diseases and metabolic abnormalities that may cause constipation. Constipation is a common non-specific symptom, so this tends to be tricky. Most helpful is to identify other symptoms you have along with constipation and what medical problems run in your family. Common underlying conditions are listed on the slide. The treatment is lifestyle changes and medication. Increase dietary fiber to a goal level of 20 to 25 grams. Start slowly and taper up over 1 to 2 weeks to improve tolerance. Fiber-rich foods include whole grains, whole bran, fruit, and vegetables. Avoid a diet high in processed cheese and meat. Increase fluid intake to 1.5 to 2 liters per day, but don't go nuts with the fluid. More than that is not going to do you any good. Increase physical activity if possible, and adjust toileting habits. This includes not holding it and not rushing when on the toilet. 30 minutes after breakfast is a common time for bowels to move. When sitting on the toilet, find a position where your knees are at least as high as your hips. Based on your height and the height of your toilet, you may need a small stool to rest your feet on. Oh, I probably shouldn't call that a stool. How about footrest? And while you're not rushing on the toilet, you should read a book. May I suggest my book? Sure, you knew that was coming. Didn't Get Frazzled, called The Best Fictional Portrayal of Med School Since ER by Blue Ink Review and a recent Indies Book of the Year Award finalist. There's even a story about a man with chronic constipation, so if you have constipation and want to read about constipation at the same time, I've got you covered. Okay, moving on to medication options. First line is a 2 to 4 week trial of a fiber like Metamucil or an osmotic laxative like Miralax. Examples of each family are written on the slide. You can also use these together, but pick only one medication from each family. Fiber supplements should be avoided in patients that have trouble swallowing or are frail or bedbound. If needed, switch to or add a stimulant laxative such as Dulcolax. Other popular options are stool softeners and saline laxatives. Stool softeners only soften the stool, so you get all mush, no push. They're worth using only if your stool is hard, but they will not give you a bowel movement. If you have constipation due to an opioid pain med, then be sure to use a stimulant laxative with the stool softener, and start both medications when you start the opioid. Don't wait to develop constipation first. Laxatives are best taken at bedtime. Also, take them 2 hours before or after any medications. Constipation meds can be taken orally or as enemas. If none of these options work after several weeks, then you have refractory constipation and you need to see your doctor. Complications of chronic constipation include hemorrhoids, anal fissure, fecal impaction, and rectal prolapse. There are prescription medications for constipation as detailed on the slide. The first 3 medications listed work by increasing fluid secretion to the intestines to help speed up GI transit. They lead to 1 to 2 more bowel movements per week, and tablets cost $12 per day in the U.S. The indications are irritable bowel syndrome with constipation, opioid-induced constipation, and chronic idiopathic constipation. Idiopathic is a fancy doctor word for no one knows why, so chronic idiopathic constipation really just means that you have constipation for a while and no one knows why. These medications are generally prescribed by a gastroenterologist, or at least after a workup by a gastroenterologist and after trials of the over-the-counter medication. Thank you for watching Didn't Get Frazzled Presents Constipation for Patients. For additional information, go to my website, davidzhirsch.wordpress.com, and click Videos. There you'll find all of my videos along with hyperlinks with more information on the issues discussed today. Please like the video and click subscribe so you'll be notified whenever I post another detailed video on common medical conditions. I wish you all good luck and good bowel health.